Go ahead.
All right. Hello, everyone. I'm Jackie Drew, and I'm currently the president for the IPT-HOPE, the subgroup within the World Congress that works with HIV/AIDS, oncology, and hospice and palliative care patients. And here we are for our second networking session. And today we have the great pleasure of having two excellent speakers. One is Darren Brown, and Mr. Darren Brown is from the United Kingdom, from London, and he's actually our lead for HIV/AIDS. And he's going to talk about HIV/AIDS and cancer services during the COVID epidemic. And then we'll have some time for some questions for Derek. And then Allison Kelly is joining us from Scotland, and she is a PhD candidate. She's a physical therapist first, and then she's a PhD candidate, and she's actually studying telehealth. So she'll be giving us some evidence-based information about telehealth from what she's finding. So I'm going to let Mr. Darren Brown take the stage and begin his presentation, and then I'm going to just put my face off the video so that we are not distracting him from what's going on. All right, Darren.
Thank you, Jackie, and thank you very much for the invitation to present today. Hopefully you can all hear me. I'm not sure who's controlling the slides, but I'll just say next slide, if that's okay. So to introduce myself, my name's Darren Brown. I'm a physiotherapist. I work at the Chelsea and Westminster Hospital in London, and I specialise in rehabilitation for people living with HIV and/or cancer. This presentation is by no means meant to be anything other than an attempt to bring together some of the plethora of information that we are currently bombarded with as a way of trying to understand maybe how COVID-19 may be affecting or people living with HIV and/or cancer, but also affecting those around them, including their healthcare professionals. So this presentation is going to go through a couple of topics, and the data is not really there at the moment. So there's some elements of personal reflection. Next slide, please. So what I'll be talking about is some global and UK epidemiology of COVID-19. I'm sure you're sick to the back teeth of this already, but just to give us some context. Some experiences of what we call surcharge capacity, which is basically building more capacity in our healthcare services through redeployment, which has been happening to me and my colleagues across our services in the United Kingdom. The current information that we have available on the impact of HIV and cancer services. And then, as my particular interest pertains to HIV, some of the research that's available on HIV and COVID-19. But I want to wrap it up with some lessons, because we know that HIV was a pandemic that came before COVID-19, and there were some really important lessons learned from that. And those lessons can be relevant to the context of COVID-19 now. Next slide. So in preparing for this presentation, I decided to create a slide of what has happened since this all began. And it shocked me how much has happened on a daily basis. I think we're all living this day by day, minute by minute, and so much is changing so rapidly. And so putting this together was quite cathartic for me to realize that everything is changing so quickly. If we think back to December last year, we had our first cases in Wuhan, China in December the 21st of a pneumonia of unknown origin, followed by the first death in China, first cases outside of China, and first cases in the United Kingdom in January. The World Health Organization named this disease COVID-19 in February, but we had our first death in Europe in February. It was also after that, in March, that we started to have changes to travel and economic packages to try and support people who could not go to work because of changes to stay at home or lockdown orders around the world. Being in Europe, obviously my focus in this presentation is going to be UK and Europe. So included on this timeline is some key time points. For example, when Italy went into lockdown, as that was the original epicenter, then moving into Spain and then France. And in blue, you will see the different social distancing measures, followed by closing of social venues, leading up to a UK lockdown, which happened after other countries in Europe. Next slide. So in terms of global epidemiology, this is probably already out of date, but I've tried to keep as up to date as possible. I did this last night. So the data is from the European Centre for Disease Prevention and Control and Johns Hopkins University. So in terms of total cases, there's 3,889,000 cases globally, and sadly, 271,732 people have died of this disease so far. In terms of where this is most affected, we can see in terms of total cases, the United States is disproportionately affected by this. However, in terms of total deaths, the epicenter for this is across Europe. Europe is disproportionately affected by the total number of deaths that have been reported so far. When we break that down by countries, we can see that there are more cases in Spain than there are in Italy and the UK. However, that's reversed when we start to look at the people that are sadly dying, whereby at the moment, the United Kingdom has the worst cumulative death rate in Europe. Next slide. This is from the ECDC as well. The top graph represents number of cases and the bottom graph represents number of deaths. Yellow is Europe, grey, Asia, orange, United States. What this represents is that Europe has been disproportionately affected in number of cases and in number of deaths in terms of COVID-19. Next slide. There has been arguments about how this data has been presented, as there is always with data analysis and statistics. Cumulative deaths may not necessarily be a useful way of comparing countries, and that's certainly what the UK government are telling us. However, if we look at things proportionally, for example, daily confirmed COVID-19 deaths per million on a rolling 7-day average, our pictures start to look slightly differently, and potentially the outcomes may look even worse for the UK at the moment. Next slide. In the United Kingdom, we have daily briefings, giving us data of the epidemiology and the actions that are taking place. And to be clear, the United Kingdom is 4 countries of England, Scotland, Northern Ireland, and Wales. These daily press briefings give us information, and the press briefing happens at 5 p.m. daily. Yesterday, we had new updates on the impact of people's movement during lockdown through social distancing measures. As you can see, most people are staying at home and are not traveling. However, what's interesting is there are sometimes peaks in people's movement, and we can see that that tends to be associated with bank holiday weekends and sunshine. Next slide. In terms of testing, the United Kingdom has been originally testing people that were in hospital and then expanding to outside of that in community settings. The United Kingdom has been building its capacity to test. However, there have been political arguments about this. There was a target to reach 100,000 daily tests by the end of April. That was achieved by the end of April, however, has not been achieved again since. Next slide. In terms of cases from testing, the blue represents people that have been diagnosed in NHS swab testing facilities, so that includes hospitals, and the orange represents external facilities such as universities, research institutes, and companies. As you can see, there hasn't really been a steady decline in cases. And we, for example, as of yesterday, there were additional 4,649 new COVID-19 cases yesterday in the United Kingdom. Next slide. In terms of people that had been admitted to hospital, we saw our peak was in the middle of April, around Easter period. This was disproportionately affecting London, as you can see by the top orange line. London was the UK epicenter of COVID-19 in terms of people admitted to hospital with COVID-19. But as you can see, this is now reducing. To caveat that, it is important to recognise that 80% of people in the United Kingdom are presenting with a mild illness. So those people that are presenting to hospital are the most sick, often requiring critical care. Next slide. And so therefore, in terms of our critical care bed capacity, this slide represents the critical care availability of beds across England, Northern Ireland, Wales and Scotland, therefore all 4 nations of the United Kingdom. And as you can see, the amount of beds that were utilised were again during our peak over the Easter weekend in the middle of April, and we are currently running at having about a third capacity of beds in the intensive care and high dependency critical care spaces. Next slide. And then unfortunately we come on to the tragic figure of daily recorded deaths. In the United Kingdom, we are still seeing a high level of deaths. For example, yesterday, sadly, they reported another 626 deaths in a 24-hour period. The blue line represents daily reporting, and the trend, which is the orange line, is a 7-day rolling average. The purpose for that is because there is that this data is all to do with how the data is reported and collected, and as you can see, every weekend there is a reduction in numbers due to the way the data is collected. So the 7-day rolling average is indicating that we are seeing a reduction in deaths in all settings in the United Kingdom. Next slide. However, what's really interesting is that Public Health England have been able to start to look at the data of all-cause mortality. There are arguments about how data is collected for international comparisons and the move towards collecting all-cause mortality data. What you can see here is all-cause mortality by year, for example, 2015, 2016, 2017, 2018, 2019, and the most recent 2020, with also the most virulent strain of flu virus per year. What you can see is the enormous spike in all-cause mortality deaths this year in comparison to all other years with flu. Next slide. Our United Kingdom government are also looking at international comparisons, even with cumulative death rates. And what we can see here is that unfortunately the United States is having the highest burden in terms of cumulative deaths. However, they do have a much higher population. And we can see here that the UK is coming out second in the world and worst in Europe. You'll see it says UK all settings, and there's a reason for that, because originally deaths were only being reported in hospitals. However, we are now seeing the data including people in care homes and in other care facilities, including the community. Next slide. So hopefully not to bore you with data, that just kind of gives us a bit of a ground setting of where we are, what's been going on. And I wanted to talk about my own personal experiences of working not only in a country that is now having the highest death rates, but also in a city that is the epicenter in the UK, and working on effectively the front lines. We needed to build our capacity because we saw what was coming, because we saw what was happening in Italy and Spain. We needed to create space in our hospitals. So we were doing what was called surcharge capacity building. And because of that, staff were redeployed from outpatient and community settings into inpatient settings. I personally found this timeline really cathartic to make me feel more at ease with why I feel so uncertain, and I felt so up and down, and at times really quite emotional, because everything has been changing on a daily and a weekly basis. 10 weeks ago, only 10 weeks ago, I was in my job doing my normal role of a HIV oncology and palliative care physio, providing inpatient and outpatient care. And that week was the week that we had the first 2 inpatient admissions with diagnosed COVID-19 at my hospital. They were put onto the ward that I work on, although I was not treating these patients. The reason they were put there is because we are an infectious disease unit. We have negative pressure fibrin. But the following week, we were then redeployed to another setting because our ward that we normally work on was the designated ward for coronavirus. So we moved our patients to an acute medical ward, and we inherited some other acute medical patients, and we supported the surcharge capacity. We were expediting discharge, getting people out of hospital safely. We were providing ongoing rehabilitation to expedite discharge. The following week, I unfortunately came down myself with symptoms of COVID-19. And in the United Kingdom, you are to return to work after 7 days. So the following week, I returned to work. And at that point, I'd then be redeployed into a different team. Our hospital had been split into COVID-19 positive and COVID-19 negative areas. And our rehabilitation, so for example, our physio and OT teams were split into respiratory and rehab teams. I was put into the rehab team, but also covered respiratory in a COVID-19 high dependency unit. where people were being provided with non-invasive ventilation, oxygen therapy, and required ongoing rehabilitation. During that time, I only treated 2 people living with HIV and 1 person living with cancer. The following week, I was then redeployed into an intensive care setting because our hospital led really well. Our leadership was amazing to meet the needs of what was going on. They created new rotas so that physiotherapists were working more than they would have been previously, in larger numbers. And I was deployed into the intensive care unit, and at that time was all COVID-19. The following week, we then started our 24-hour shift across the intensive care and respiratory team. The week after that, I was able to access an antibody test, and I was tested positive for COVID-19. The week after that, continued to work these shift patterns because I live too far away from the hospital I work in, and there's reduction in public transportation, and working until midnight. I was having to sleep in hotels and be away from home for 4 to 5 days, just going to and from work and staying at the hotel near work. And then the following week, we saw the hope. Less people in intensive care, people starting to rehabilitate, people starting to wean off ventilators, people getting tracheostomies and getting trachea weaning, people being stepped down to acute medical wards, people getting out of hospital. So we reduced our 24-hour service. So last week, this week even, I've been back in my normal team, although not in my normal setting, working in different wards. We still don't have outpatient services, but we still have inpatient services. I'm still working on rotas, but they're slightly different now. We're now focusing more on rehabilitation. Next slide. I wanted to talk about the shifts that we had. Our normal day shifts are from 8:30 to 4:30, but because of this ability to redeploy staff, create capacity, and deliver more services, we also had a twilight shift, which was working from 4 until midnight, and then also an overnight shift that was working from 8 p.m. until 8 a.m. At times, there may have been 10 physiotherapists working at 10 p.m. at night in our intensive care unit, supporting our nursing colleagues by covering breaks, by supporting patients with repositioning, by helping our anaesthetists and operating department practitioners with proning, by providing chest physiotherapy interventions, by looking at weaning plans, by providing rehabilitation. This was incredibly rewarding, challenging, and also daunting for myself and my colleagues that I worked with. Next slide. I asked my colleagues on a night shift, when there were 10 of us working at 10 p.m, if you could describe one word to represent your experiences of discharge capacity and redeployment, what would it be? This is what my colleagues said to me. They were proud, they were stressed, they were emotional, they had an appreciation of life. I felt really proud to be doing what I was doing, but I did feel overwhelmed. I felt uplifted. I felt there were expectations on us to be certain things and do everything for everybody. There was fear, but what really stuck with me was what one colleague told me about being dispossessed. They said that they remember being a physio during the 80s, and they themselves identified as a gay man, and remembered living through the HIV pandemic, and how at that time, disproportionately gay men were affected by HIV in the UK. And therefore, there was stigma, marginalization, and oppression towards those people. He recalled how now everybody's affected by this virus, although at different proportions. And therefore, how dispossessed that felt in terms of that pandemic compared to now. However, felt really rewarded at the adaptation of staff and the ability of physiotherapists to step up to the mark now and act in every role possible to work through this pandemic. Next slide. It made me realize the importance of being a versatilist. As a physio working in HIV, oncology, and palliative care, I've always described myself as a versatilist. I may be a specialist in these disease areas, but I need to work across systemic bodily issues that are physical, psychological, social. I think all physiotherapists that have stepped up to the mark in this pandemic have demonstrated the versatility in their skills. And I'm so proud to call myself a physiotherapist and been able to work across all these different dynamic areas. Every single day and every single week of that timeline that I presented of my personal experiences, I needed to draw on my versatile skills as a physiotherapist. And I think all of us have demonstrated that globally. Next slide. I want to touch on impact on cancer services. In the United Kingdom, we've got some really innovative ways of doing this, and there's huge collaborations happening with UK coronavirus cancer monitoring. They are recording people living with and beyond cancer that have been diagnosed with COVID-19, the comorbidities they're living with, the symptoms that they may be experiencing, which is demonstrating that they may be experiencing at more severe levels than the general population. And also sex distribution, which in the United Kingdom and globally, we know that men are more affected by COVID-19. However, that seems to be equally distributed for cancer, people living with and beyond cancer. Next slide. Unfortunately, data is demonstrating that due to COVID-19, there has been a 76% reduction in urgent cancer referrals. There has been a 60% reduction in the provision of chemotherapy. And it's predicted to be an increase of 20% deaths in the next year of people living with and beyond cancer. If we were to put that into numbers, that would be an additional 18,000 deaths in the next year for people diagnosed with cancer. In the UK, in the US, that would be 34,000 additional deaths. Next slide. Dr. Newsom Davis is the acute oncology consultant in the hospital I work at Chelsea and Westminster. And Twitter's been a great place for us to share information at the moment. And I think we've seen that in our global physiotherapy community. His data has demonstrated that there's been a reduction in the early parts of the pandemic for people being referred to the acute diagnosis of cancer clinics at our hospital. As you can see by that graph, a significant reduction. However, what we're seeing now in his most recent tweet on the 1st of May is a tripling in the number of people that are now presenting to hospital with cancer. People stayed away from our hospitals, and we've seen this across many different health conditions. Where were the heart attacks? Where were the strokes? Where were the people with cancer? Where were the people with HIV? They weren't presenting to our hospitals during COVID-19 surge and peak, but we're seeing people presenting now. Next slide. In terms of impact of HIV services, there is lots of data on this already around maintaining HIV care, including in the Lancet article, which talked about the importance of testing, linkages into care, and also access and continuation of antiretroviral therapy. The British HIV Association, or BEVA, have also provided guidance on the management of adults with antiretroviral therapy in COVID-19 pandemic. And what's really important is that because of the success of antiretroviral therapy, people may not need to see their HIV clinics very often. So there are services that have evolved to do home delivery and pharmacy pickup. HIV services may have been less impacted by this in terms of people being able to continue with their treatment. However, testing has also been something that needs to continue. Interestingly, 5016 Street, which is the clinic in the trust I work in, has identified that potentially COVID-19 may have broken the HIV transmission link. Less people are hooking up, less people are having sex, so therefore, less people that are infectious are passing on the virus. They are encouraging everybody to test now for HIV and all other sexual health conditions, because this is the time that we could break the HIV chain. This is a once in a lifetime opportunity. Next slide. In terms of the HIV rehabilitation services we provide at Chelsea and Westminster, which includes clinics and group rehab classes, I took the unilateral decision on the day after the World Health Organization declared a global pandemic to suspend our services. Not because people living with HIV were at greater risk of COVID-19, but because one, we were being redeployed. We were surcharge capacity building, but also because the majority of people that come to my service are older, which is a risk factor for COVID-19, and living with multimorbidity, another risk factor for COVID-19. So it wasn't that HIV was the risk factor, it was their other problems, such as age and comorbidity. So I suspended the services and I offered all of them telehealth. 73 people were offered telehealth. Only one actually requested to be phoned about their ongoing one-to-one treatment. One person asked for a group Zoom thing like this. However, due to being deployed everywhere, I couldn't do that on my own. We did update our website, as you can see, to try and support people to be active at home and engage in ongoing rehabilitation. Next slide. But rehabilitation has had a really great opportunity during this pandemic. It's really taken a center stage at points. There has been identification in the media about the tsunami of rehabilitation that will be required, not only because of coronavirus, but also across the continuum of care. Our representative organisations, such as the Chartered Society of Physiotherapy, have been promoting and highlighting this, and we are seeing physiotherapists on the news frequently. We've also had policy statements produced and guidelines from the British Society of Rehabilitation Medicine. Next slide. And there are publications about the importance of rehabilitation. This publication in BMJ Global Health, published this week, was about maintaining essential rehabilitation services across the continuum of care, highlighting that rehabilitation services are essential and need to continue, that rehabilitation services have been affected by COVID-19. And this has been shown across 12 different low, middle and high income countries in this paper. The call for measurement, a uniform measurement approach. Tele-rehabilitation will be necessary and collaboration is key, and PPE is needed. It was a call for global collaboration and strong leadership. Next slide. So what's the research on HIV and COVID-19? Well, the European AIDS Clinical Society, EACS, and British HIV Association, BEVA, are providing us with a nice summary of this research. There is currently no evidence that people living with HIV are at greater risk of COVID-19. And this has been borne out of 3 particular studies. So the first is by Blanco in 2020, published in The Lancet, which was from Barcelona in Spain, which has shown that 5 people living with HIV have presented with COVID-19. 4 of those were undetectable, meaning the virus was well controlled. 1 of them presented as a late presenter with advanced HIV. The second study, which is in preprint at the minute, again in Lancet, which is by Guo in 2020, was of only 8 people living with HIV. And the other paper that's also in preprint in JAMA is by Richardson in 2020, which was a case series in New York City, looking at 5,700 people with coronavirus and what comorbidities were most prevalent. What they found is that only 43 people were living with HIV across this group, which was a prevalence rate of 0.8%, whereas in New York City, the prevalence of HIV for the population is 1.3%. So they identified that HIV itself is not a risk factor. So we know that with COVID-19, risk of severe illness is increased with age, male sex, and certain concurrent health conditions. So although we know that people living with HIV on treatment can achieve viral suppression and a good CD4 count, may not be at increased risk of COVID-19, it may be that the other health conditions may be the problem. So we know that in Europe, more than 50% of people living with HIV are over the age of 50 and also live with a concurrent health condition. Something else we also need to consider is that if people cannot access care and treatment, they cannot be undetectable. So therefore, it is presumed that immune suppression will therefore increase the risk of COVID-19. Next slide. In the United Kingdom, we have achieved the UNAIDS 1990 targets, where more than 90% of people are tested and not more than 90% are treated and more than 90% are undetectable. So therefore in the United Kingdom, we are therefore quite clear to say that people living with HIV are retained in care, are achieving undetectability and therefore are not at higher risk of COVID-19 because of HIV. Next slide. So what are the lessons? The lessons are big from HIV. The reasons being is because there's similarities. There is no vaccine for either HIV or COVID-19. And also, there are currently no licensed pharmaceutical medicines to treat COVID-19, just like there wasn't for HIV in the early days of the epidemic. We also know that population behaviour will determine the pandemic trajectory of COVID-19, just like it did for HIV. So what are the 3 key lessons that are published in this paper? The first is there is need to anticipate health inequalities. We know the pandemic HIV transmission was accelerated among mobile and well-connected networks. But the burden shifted to poorer people and poorer countries, particularly young women and marginalised groups. So therefore, what the lesson is we must track socioeconomic status and gender of those affected by COVID-19 so that we do not leave anybody behind. We know that often new advances in treatment and care rapidly benefit those that are better off. So therefore, we must have global policy that prioritises access to innovations, for example, rehabilitation, for those with the greatest need. And our efforts should not increase inequality. Secondly, we need to create enabling environments to support behaviour change. So fast, decisive political leadership is crucial. The lessons from HIV is that supporting safer behaviours means that we must address the structures that constrain and enable people's choices. For example, just like gender-based violence hindered safer sexual practices of women, we know that no access to clean water may hinder people's access to hand washing. Modern approaches to HIV prevention are driven by social ecological frameworks with meaningful engagement of communities to shape social norms. So therefore, the COVID-19 response must include older people, those with comorbidities, and those already living at the margins of society. And we must avoid unintended social consequences, for example, laws that can contribute to blaming in society. This reminds me of the 1980s, where in the United Kingdom, there was a law that was produced called Section 28, which meant that during the height of the HIV pandemic in the UK, our government promoted that gay lifestyles could not be promoted. So for example, there was no education on sexual and reproductive health in gay communities. This had a long-lasting impact, and it created blame among gay people for spreading HIV at that time. We cannot allow stigma in COVID-19. We must think about our language. We must think about what we do and how we act, and we must not marginalize and oppress people. For example, stigma in COVID-19 could affect the ability of people to self-quarantine. And then lastly, the multidisciplinary effort that is essential. We must design, characterize, and evaluate interventions that shape behavior. Innovative elements of the HIV response have included structured community mobilization, targeted social protection, and differentiated healthcare delivery. There are arguments and discussions at the moment about differentiated pathways of rehabilitation for people with COVID-19. Now, do we need that? Do we not need that? I don't know. I haven't got those answers, but there's someone shouting, can we move? We know that in the context of ITU step down and critical care rehabilitation, there is fractured and fragmented services already, irrespective of COVID-19. But COVID-19 may be highlighting the importance of what's needed about them. Next slide. Inequality will spread COVID-19. And if you haven't seen this video by Emily Maitlis, I would highly encourage you to watch the YouTube video. She identifies that COVID-19 is not the great equalizer. Next slide. Because we know that in the UK, coronavirus has proportionally had a higher impact on those that live in the most deprived areas. People presenting to intensive care are disproportionately from BAME backgrounds. And also, those people that are dying working on the front lines are disproportionately from Black, Asian, and minority ethnic backgrounds. Next slide. COVID-19 and inequality has been most recently represented by the impact of COVID-19 in terms of ethnicity. For example, the increased risk across BAME communities in comparison to white people, mostly driven by deprivation and inequalities in health. Next slide. Which is why our government are saying they're going to look into these things across all of the different areas that could impact on health inequality and outcomes. Next slide. We mustn't forget that potentially people living with disabilities may be affected. During lockdown, people that may not be able to access care or rehabilitation at home. Next slide. People that are homeless, they require care. They require services, they require support. We know that people that are homeless are also at increase of other viruses and other diseases, just like they will be with COVID-19. Next slide. But then what can we learn? Gay men in Europe, for example, lived through a HIV pandemic. HIV was always in their lives. I can attest to that. HIV has always been in my life, even though I may be HIV negative as a gay man. But what are the lessons we can learn in terms of shaping cultural norms and social behaviours? We learned in HIV around condom use, adaptation and adoption of pre-exposure prophylaxis, and understanding of U equals U or undetectable equals untransmittable. talking about openly our health statuses and sharing that information? What can we learn from the past experiences in other pandemics towards COVID-19? Next slide. And then what can we learn from rehabilitation? In the context of HIV, we have talked about how disability experienced by people living with HIV is multidimensional and episodic, or fluctuating. We're seeing this bear out in COVID-19. It's unsurprising that when you have a virus that affects systemically many different body systems, that you may have multimorbidity and multidimensional disability, whether that be HIV or whether that be COVID-19. Additionally, I would anticipate that potentially uncertainty or worrying about future health, which is a dimension of the episodic disability framework in HIV, may have useful connotations in the context of COVID-19. Next slide. The lessons we can learn from HIV rehabilitation is about the role and the framework that we adopt as physiotherapists in working with people living with HIV, in being client-centered, crossing physical, psychological, and social aspects of rehabilitation care, but understanding the contextual factors that we need to consider. For example, age, the episodic nature of disability, multimorbidity, competing priorities, continuity of care, stigma, resource security, and social isolation. Next slide. And then lastly, about collaboration and networking. This paper talks about how bringing together people across rehabilitation in the context of HIV and other chronic health conditions has identified shared knowledge and skills, has created new ideas for research and collaboration to piece the puzzle together so that we can accelerate data collection and advance care for people living with HIV and other health conditions. And I would propose that the global physiotherapy community has been amazing at collaborating. And I'd like to, around COVID-19, and I'd like to applaud all that is being done. For example, like what we're doing now. Next slide. So I don't have a conclusion slide because I don't think I've got any conclusions. What I want to do is say, what are your questions? What have you learned? What are your learning points from your own lived experiences across time, but also during this time? Thank you very much.
Thank you, Darren. That was amazing. You're so insightful about the path forward and carving a path forward. I guess what we'd like to do now is have questions from the audience. So if you have a question, if you could raise your hand in the bar at the bottom, and then Ann Newstead will unmute you and then you can speak. Or if you have a question, you can go into the chat room and then Darren can answer the questions from the chat room. So anybody have any questions? Darren, that was...
Imad does. Thank you, Darren. Wonderful. Thank you, thank you.
Thank you so much for this, I would say, amazing lecture. It's kind of an eye-opener for us people that are living in the Middle East, and to see how the HIV people are somehow neglected in our management, and how is that completely different from the COVID-19 right now, because we can see it as a pandemic and a lot of people are affected by it because it's a global problem, while actually HIV is also a global problem. It was not, I didn't have a question, I just wanted to mention that. And just again, thank you so much for such amazing lecture.
Thank you, Imad.
Thank you.
Anyone else? I see a message from Aya Oni. She said that they said it was very insightful, your presentation.
Thank you.
Any other comments here? Let's look at the chat line. Most of the things are exceptional as always, Darren. Thank you so much for sharing your live experiences. And that's Nina Chegbo from Nigeria. Carolyn said, thanks, Darren, this was excellent. From Anne, thank you, Darren, and for sharing your expertise and experiences. And then I said, Io Oni said it was insightful. And then John Davidson, Okwudili said, thank you, Darren, it's very interesting. So a lot of positive comments. I'm just blown away with how you've been able to take the experiences from HIV and put them together as to what's happening now with the virus, and then do activities that are preventative, because it seems like so many of the people that had sent me messages, as well as my country, we were not prepared. And there was a lot of sad reasons for us not being prepared, where we could have been prepared. And, you know, sadly, people were shutting down physical therapy units or, you know, closing outpatient. But from people that were being really successful with this, like my colleague Ann Newstead, they knew how to use preventative measures, how to keep the patients safe, and when it was okay to treat them and not. And so rather than just shutting the door on rehab for our profession and our patients, there's so many things that we can. And I'm hoping going forward, before we get the next waves of things, that we can be proactive, like you talked about the surcharge, where you were getting materials ready, taking materials out of places that, you know, could handle for a short period of time being shut down to be on the front line. So this was just amazing, Darren. Does anyone have any other questions? There's some questions in the chat room again. It says, hello, everyone. Actions you made with HIV. And then from Geeta, thank you, Darren, for all the data and the process of working during COVID time at your place. My internet, okay. You put value in rehabilitation as well as tying HIV and COVIDs. And so everything, all the comments are very positive. Any specific questions? Dr. Remalukin, Dorojeli, I'm sorry, I'm not pronouncing that correctly, but he's saying that it was great to hear how quickly your department.
Yeah, if I can, I'd like to respond to that comment and congratulate the leaders and staff of where I work, and I am sure this has been mirrored in many places, but I don't work in many places, so I can't say that has been, that have responded so rapidly, including all the staff that have had to change their working patterns, working overnight, working in evenings, working in different teams, working in different settings, and the uncertainty that creates for staff. I think certainly it's been an emotional roller coaster. Personally, for me, I have cried many times over this journey. And I want to say thank you to all of the people that have led us during this, whether that be from a global or a local level. For example, I'd like to thank Laura Swanson, our lead respiratory physio, who put these rotors together and enabled us to work together to respond to this.
Mm-hmm. Yeah. Darren, there's another question. It's from Adaora Okimuo, and she says, thanks a lot, Darren. Please, why are the Black frontline health workers marginalized and are at the most risk of dying? Is it that when they fall sick, they are not well taken care of as much as others?
That is an incredibly important question that I cannot answer. I think it's a question that needs to be answered at a much higher level. What we're seeing at the minute in such early stages is data collection. And we need to look at the structural racism that's taking place as to why. I haven't got that answer.
Okay, thank you. I have a couple of people that are saying how much they love the term versatilist, Imad Bashir, and from Anne. And John Davidson Okwudili asks, what makes one a versatilist? Between specialist and versatilist, which one is superior?
Oh, there's no superiority, is there? It's differences. The slide kind of makes it clear, you know, a specialist is within a narrow area, but maybe has a higher level of skill in that particular area. But a versatilist has high levels of skill, but just across a more broader range. So for example, if I talk about myself, you know, I'm a physio, I specialize in HIV and cancer. As a versatilist, I can treat patients that present to me with respiratory, neurological, musculoskeletal, complex psychosocial challenges. But I'm not going to say that I'm a neurological specialist physio because I don't deal with neurological issues all day long. but I can address those in the context of HIV. So I would say that's where a versus list comes in. I can see there's another question from Malawi. Do you want me to answer that? Which was...
Yes, please, Darren.
Oh, it's moving quick. Thanks for the presentation. Just wanted to know how important physio's role will be in rehabilitation of patients with COVID-19 post-recovery, irrespective of cancer, HIV. Absolutely. You know, when people have a disease and have impairments of body function or structure or any disability, rehabilitation is imperative, and rehabilitation is essential. Rehabilitation is essential for those with and without COVID-19 that experience any type of disability. And so I think that what COVID-19 has done is shine a light on that.
Darren, can you give your perspective on why, if you've seen Black frontline health workers be marginalized, and being people of color, we're noticing here in the US, are at more risk of dying from COVID? Any comments on that?
I think again it's similar to the last question. I haven't got those answers. I think we need to look at social inequalities, health inequalities that affect different groups of people and why. You could pin it down to structural racism as to why people are marginalized, but that is different in different parts of the world. And what are the policies that lead to that? You know, I'm a privileged white man. I don't have that lived experience, so I can't talk about that, but I can talk to data and say that it's there, and I look to our leadership to look at that. I know that the APTA recently did a webinar similar to this on that particular issue.
And possibly access to care, or possibly access to PPE, or problems with transportation or challenges with transportation, getting to and from. You mentioned you stayed in a facility nearby. Could that impact people as well?
So in terms of where I work, the local communities and our hospital stepped up immensely, where we were provided with food from local food establishments, so that people that were working long shifts and couldn't access food were able to eat whilst at work. And also for those people that couldn't travel because our reduction in transportation systems were in place, we were able to stay in hotels that were provided free to the hospital.
I'd like to highlight Nancy Minglegreen has a comment here that she's from the New York and the New Jersey area. And here in the US, in her area, the leadership came from local leaders, including in the hospital and local governments. And from what she knows, that their acute care hospitals here in New York and New Jersey, our PTs have been mobilized in a similar manner as they have in the UK. And so she thanks you for your insightful presentation. And I'm so glad that you brought that to the forefront, Nancy, because I'm in Southeast Michigan around the Detroit area. And, you know, the people that were sadly the most affected by this were people who were African-American, who are living, you know, they're citizens of the US, but they're from Detroit, and they had the highest infection rates and, you know, the highest death rates. So, you know, different regions are addressing it differently. Some regions are, you know, we're just not prepared going into this. And really the local leaders and the governors were the ones that, you know, are stepping up. And now we're starting to see, but even the local leaders and the governors are getting a lot of pushback from other leaders. And, you know, some of the people in the community are not obeying the no mask rules. So of course there's going to be, you know, sadness and increases in the numbers. And I was so interested with what you said about the sunny days and the holidays, Darren, that the rates went up, you know, because people had let their guard down. They're not, you know, in the arena that we're in as far as professionals having to be always on the alert for things like that. So You know, I do have one question. Right now, actually today, our acute care section, our cardiopulmonary section is doing a networking session like this one, an educational session, where they're talking about putting people with COVID and the lung problems on their stomach rather than their back. Was that something that the UK was doing, and what are your thoughts about that?
So I believe you're referencing proning.
Yes.
So proning is something that has been used for ventilated patients with ARDS, or acute respiratory distress syndrome, for a while. It's not a new technique. However, because patients were so hypoxemic when they were mechanically ventilated in the intensive care setting, they needed to try and improve that oxygenation. So proning was a technique that was used and was successful. So in our redeployment into the intensive care setting, we were working within proning teams effectively. So the anaesthetist would be on the endotracheal tube, and then there'll be 6 other people that would then turn the patient onto their stomach and then turn the patient back again 6 hours later, or less or more as needed. There's been arguments about proning of the non-ventilated patients. There's no evidence that that works. For example, patients with non-invasive ventilation like CPAP or BiPAP, it's also probably very uncomfortable and probably wouldn't be maintained for those patients. So I think that certainly I'm not going to pretend that I'm a specialist in respiratory, and I'm sure there's plenty of other people that could say much more to that. But yes, we were proning mechanically ventilated patients.
Okay. There's also a comment again from Nancy Minglegreen, and she says, I'm a faculty member in a PT program in New Jersey. Can you tell us how the crisis has impacted physical therapist student education in the UK? And are students allowed to treat patients with COVID? And are they still allowed in the hospitals for internships?
That's a really, really good question. So at the very beginning of my timeline that I gave you, where I said I was working in my normal role, I had a student who was on placement with me. And this student was with me even after I came back from my own sick leave, was still in our team. And I believe my colleague Nana is actually on this presentation today, and she might want to join in with this. He was still on placement with us throughout most of his 6-week placement, but he was actually drawn out of his placement for the very final week. Interestingly, he's now applied to be a rehabilitation assistant. He's been brought into our department and he's now working in our department. So he was treating COVID patients with us as a physiotherapy student. However, we worked really closely with his higher education institution, his university, to try and identify risk and need. And they took the decision at one point to withdraw their students. However, other universities kept their students on placement. Many universities withdrew all their students very early. I know that WCPT has released, I think it was yesterday, a new summary of education for physiotherapy and physical therapy students globally. And it's a fantastic resource indicating the mobilization of educational models to online and the implications of potential in-person practice placements. I'm not an education leader, so I'm not going to pretend that I've got all of the information, but from a personal experience, we did have students. They were removed, but some were still on placement, but most were removed.
Thank you, Darren. Can we have Nancy take the microphone? I'd like to hear what her students are doing in New Jersey. Anne, Anne
to take the microphone. Can you hear me?
Yes.
Okay, thank you for acknowledging my questions. That's awfully nice. The New York, New Jersey Consortium of Physical Therapy Educators has a very active group, and we're working together with all the programs in the New York, New Jersey area to manage a lot of the educational issues. From my knowledge, almost all of the physical therapy students from our schools were removed or asked to leave the clinic sometime around mid-March, which left many of the students unable to graduate in May as a result. I work at Rutgers University, and we made the decision to remove our students for a few reasons. The first is that about 20 of the 67 of them had already been asked to leave the clinic by the hospitals. There were a lot of outpatient centers that were closing because the patients were no longer coming in, and there was no real significant ability to do good clinical training. But the other reason we removed our students was because of the stress the added stress of having a student while the clinicians in all of the settings were dealing with not only watching their patients get worse, large fatality rates, but also a lot of them were now homeschooling their children, and they had no time. They didn't have the ability to go to the clinic on their regular schedule. And then in addition, as you've already pointed out many times, Jacqueline, our federal government, I'll be less careful about what I say, our federal government was wholly unprepared to help any of the states with PPE. And so a lot of our students were asked to leave because the clinical sites didn't have enough PPE for their own staff. And as a result, they were furloughing their staff. They were not willing and were not able at Rutgers to pay for enough PPE to get the students through. So it was very much based on a variety of factors.
Yeah, Nancy, I'm a faculty member too, and we had very similar experiences, but you know, within the Detroit area, the hospital PT departments were closed. I know one hospital where the PTs were redeployed as being at the entrances of the hospital, taking temperatures and screening and asking people questions that were staff coming in. So there were even the inpatient PT was largely not being used. Now that wasn't true for outstate hospitals, you know, like mid-Michigan and other places, because they were more like, you know, what you were saying, that the inpatient was still working and doing rehab, the inpatient PTs. But, you know, our universities here in Michigan, they closed on May the 10th. No, I'm sorry, not May, around March the 10th, and everything went online, and it's online all summer. And, you know, since there was a lot of PTs, clinical practices closed, there was no place for the students to go. And then we had issues since our university was physically closed, it was all online, that the hands-on classes, they've got them set where they are going to teach as much didactically as they can, and then they've added extra hours in the fall, hoping that we go back so that they can catch up on their hands-on learning and practices. Is that what you're doing at your university too, in terms of the teaching?
For the most part, we had we have a cohort of students who were supposed to go out on their first experience in the summer, and we canceled that based on a survey we did of the sites. The sites are not ready to take our students back. And now we're surveying the sites for CE2, which starts in August and goes through the fall, to find out if that's going to fly as well. So feel free to reach out to me at Rutgers and we can talk more.
Nancy, Jackie, if I can just add from a Scotland point of view. So I'm a lecturer in Queen Margaret University here. And when COVID-19 came, we did pull all of our students from placement because of the risk to our students, and because these students aren't on employment contracts. So, you know, the health conditions as well that some students may or may not have, and as Darren mentioned, you know, the risk assessment. But the CSP over here in the UK and the HCPC, our professional council, have been, you know, extremely supportive and have done have set up what we call a temporary register to get our students who are in their final year out ready into the clinical practice, and any remaining hours that we are still supporting them, even though they are on employment contracts, as a junior band 5 for, let's say, the first month or so. So, you know, our role as academic tutors and, you know, to support students in their first employment is quite important. But as Nancy said there, for our first year students who should be going out on foundational placements, yes, we've had to pull that. but we are front loading theory at the moment. We're still teaching online. So here in Scotland, we teach during the summer. We've got master's students as well then as our September cohort starting again. We will be online. However, as you guys said as well, we're making plans for more didactic teaching, blended learning type approaches. But yeah, it was about that risk to the students. And as Darren had mentioned in his presentation as well, there will be a tsunami of rehabilitation of patients to come. And, you know, our students are an extremely valuable part of the workforce here in the UK. And, you know, we need to get them ready for that as well with their experiences.
Yes, thank you. Thank you, Allison.
Can I mention, this is Anna, can I mention, thank you, Allison. There's a follow-up question to that, and that was, I can't see who it's from, but a quick question. Are there mechanisms put in place for physiotherapy follow-up on patients following discharge? Could you elaborate on the timeframes within which you could discharge a patient from physiotherapy following COVID? And I'm seeing that's more as a rehab question as well, Darren. Can you address that, please?
Yeah, I can try. So just to clarify, the question, is there community follow-up in terms of rehabilitation following discharge from hospital with COVID-19? Is that the question?
That's how I read it. Yes, sir.
Okay. So in terms of what exists, people that are diagnosed with COVID-19 that have stepped down from hospital to community settings are able to access those existing community services. I think the big question that's happening now is the existing fragmentation of services that specifically address post-critical care acquired weakness. People that specialize in that area have gone on about this for so long, about how it's been deprioritized. And I hope that, to put a positive spin on a terrible situation, that the post-critical care rehabilitation agenda is prioritized because of this pandemic. Yes, there are rehab services that are available in the community. There are talks about, for example, whether COVID-19 specific rehab pathways are required. I think this is a really big policy conversation about access, about those with the most need, about not leaving people behind. And I think that we know that often community services can be underfunded. And so therefore people may not get the rehab they need, irrespective of what health conditions they live with. I'd like to think again that maybe there could be a greater prioritization of community rehabilitation in people's homes or in community settings, so that no matter what health condition you live with, COVID-19, COPD, heart failure, cancer, HIV, when you need it, you get it.
Darren, there are two return threads in some of the chat lines, and the first two I just want to mention is we have additional questions. Janet Nana, to everyone, she's asking, did your local physiotherapy governing body change their criteria to allow final year PT students, physio students, to graduate early and join the front line as is being discussed, you know, in your area? And then Nancy made the comment, yes, they did. You can see the statement and modifications through our CAPTI guidelines that are listed on the chat line if anyone wants to get them. So our inpatient rehab hospitals have opened COVID units with their centers. Patients who have been very ill and need rehab have places to go. So, you know, there's some mobilization of students, as has occurred with nursing students. There are some that have been graduated early and, they've begun working here. The other thing is going back to the inequalities, and this is an important question. This is from Nicola Day. I don't know if you can see the chat line, but she says there have been lots of theories about why the BAME group have been disproportionately affected by CV-19, which include large ethnic populations in most of our affected areas, London, Birmingham, as well as greater numbers living in close family groups, though undoubtedly there are some associated health inequalities, but not in their care received. I would not consider that people from BAME groups are treated less well than other groups within our UK healthcare system. And I can assure you that at NHS staff from BAME backgrounds are just as valued within our workforce as every other member. So that's an interesting comment that, you know, they don't have the comorbidities, but it's the behavior or living situation, you know, like you talked about with the early HIV/AIDS, that may be a contributing factor for what's going on. Do you want to comment back on that?
I don't think I have much to comment on that, because I think, you know, talking about health inequalities and the structures that drive those are the ever repeating issues of the health issues that many people face. I think that with this pandemic affecting anybody, it's brought it to the fore. But it's not the first time we've seen this. You know, if we go back to HIV, LGBT community, young women, sex workers, migrants, all marginalised groups, all people that are disproportionately affected by HIV, but now it's coming to the fore because we have a virus that seems to be much more contagious, is an airborne virus, so therefore affects everybody. And I think that the health inequalities are still there. The health inequalities and the policies and the governmental laws that drive them are still there. And how we address those is by, first of all, recognizing them. And I'm pleased that now everybody is recognizing them. And I want to echo what Nicola said. Certainly in my presentation, I hope it didn't come across that anybody was undervalued. Certainly everyone is valued. We all have access to the right PPE at the right time, whoever we are and whatever characteristics we have.
And then Imad Bashir, do you want to make your comment, Imad?
I mean, I'm just going to comment on what was written about the BAME group. I would understand that this would increase the rate of infection, but the rate of dying or the death rate is something else that needs to be somehow addressed. Yes, if they're living in larger groups or their communication that's happening can increase the infection rate or the rate of the positive patients, but the death rate, this is a questionable thing that needs somehow to be answered.
Thank you. Thank you. Okay, Darren, any thoughts?
I'm really pleased how much this has generated discussion around what appears to be health inequality. Seems to be something that's been really triggered by this, and I'm really pleased for that. I'm really pleased that we're having this open dialogue, and I hope that from this there are opportunities to learn from the past so that we don't make the same mistakes in the future. And that's why I'm really pleased that we're having this conversation.
Okay. And Nancy has another comment here. I believe that the presence of a national health plan in the UK may be a better equalizer for BAME to obtain health care. In the US, again, we don't have this, and so access to health care by the BAME population is more limited.
We are incredibly privileged in the United Kingdom, in which that we have universal access to healthcare at the point of need. It is not dependent on having insurance. It is not dependent on the money that you earn. It's paid through by our taxation system. We are privileged. However, it hasn't stopped us having the worst death rate in Europe. I don't know how to continue with that other than leave it at that point.
Okay, there's a comment, another comment from Nicola Day. She agrees with you regarding community rehabilitation. All of our community services stopped and the staff were redeployed. They are now starting to reopen, but only for CV-19 patients. And then she asks, what will happen to our stroke, cancer, elderly care patients in the meantime? She says she works in the acute trust, and we have set up a task force to address, define, and implement pathways for both COVID and non-COVID patients.
it's really interesting to hear how people are locally addressing their issues for the populations that they treat. I think that's why it's so important that we share experiences, and I'd love to hear more about that.
Yes, and I think this is the point about being preventative or proactive, and I think that's how PTs operate. You know, we plan things in advance, we get evidence from practice, and we're just in an area right now where there is so little evidence. We're just going by our best judgments and opinions and what little evidence that we do have. And if we get a little breather here before, you know, winter, when supposedly there's supposed to be more of the COVID coming, or the fall, maybe we can be more proactive and plan so that we're not going through 24-hour shifts, or, you know, living in a hotel room, you know, near the hospital. But most importantly, that patients get better care so that they're not seen in such end stages of sickness, or missing care, even if they don't have a COVID diagnosis, or, you know, have other emergency care issues. Any final comments?
This is Mary Lou Galantino, and I just really want to applaud Darren, and this whole conversation is so deeply needed. I had one student that said, as I'm teaching online this semester, we transferred everything over, I thought we were essential.
Yeah.
I thought we were essential. And to not be deployed in this time when we have so many students that wanted to go out, including all of us, all of the clinicians that have been furloughed here in the United States, it's really a time of recognizing where our role is. And one of the things that I have really thought about significantly is this goal of fostering immunoenhancement while quarantined. I think this is our opportunity as a profession to remind people that movement and physical activity is still so important, and that this is our opportunity to really feature physical activity to improve one's immune system as we begin to move out into society. And it's just really been an interesting journey to watch the many pivoting aspects of this. And as was so aptly stated, this level of inequality. My prayer is that after my entire lifetime of witnessing disparities, that indeed we will see a shift due to COVID-19. So I just want to thank you for these opportunities to have this rich discussion. We are all in interesting territory as we advance back into the foray here, but I do think there's so much rich research that really speaks to ways to improve one's immune system to now begin to foster that immunoenhancement as we you know, begin to open up different areas of the globe.
Mary Lou, thank you so much. That's brilliant. And I too, I really share your passion for us being told that we're not essential. I mean, I've worked in intensive care. I've worked, you know, in acute units, you know, and we make such a difference there, and we can make a difference for the, you know, as a team member. I know Darren's paper, that was one of the principles that came out in the one paper, that we are essential and we have to educate people what's going on. Ann and I have been working on a perspective paper from our last session 2 weeks ago with Nina, and we're coming up with some principles, and Darren has, you know, encouraged us and supported us that that's the first thing. We are physical therapists that are part of the team, and we are essential to what goes on. Otherwise, people don't get the care that they need. They have further disability, like you talked about, and they don't survive things as well. So I think it's up to us as PTs to, and our students, the, you know, future of our profession, to move forward and to let people know how we can help, what we can do, what's going to help people survive this, and not just survive it, but be successful and have a better quality of life. So thank you so much for your insight and your comments, Mary Lou.
Thank you, Jackie. It's great to see everyone.
Yeah, good to see everyone. There is a comment from Southeast Michigan, and it's from Amelia Louise Ferdinand. Many of the hospital-based health systems in Southeast Michigan have furloughed their outpatient ambulatory rehab staff. I worry that this will impact our ability to be proactive in managing COVID and non-COVID care. So yes, again, supporting what we're all talking about here. And then Anne says everyone deserves care. Good points, Mary Lou. Again, Anne, you can talk for yourself.
So I agree, of course, with Mary Lou and what Darren and everybody is saying. I am totally in agreement that we need to look and see how can we educate the general public to the benefits of physiotherapy in terms of health, wellness, and promotion of using exercise as medicine. And it is, what I've been doing is sending weekly newsletters to patients and people that subscribe to my newsletter instead of monthly, and promoting exercise, nutrition, along with mental health. So this is a time that we all need that support, and this is sort of a support group for all of us. So that's what I was getting at. Thank you.
And some of the things that we've talked about is that some of the cancer patients that have been delayed, if they can exercise, if we can get them into a prehab situation, there is evidence that they would be stronger moving forward as they go through their cancer and its treatment. So
right, and I've had to put off some of the patients that have cancer, have not been willing to come in, and have also said no to telehealth, which surprises me. And then again, some others that have comorbidities that have stayed home, I have been seeing good improvements with telehealth. A few of my patients have been hospitalized because of falls, because of AFib, because of other medical problems. I've had at least 3 or 4 people that have been hospitalized during this time because they haven't been getting consistent face-to-face therapy. And this will kind of go into Allison's talk, who's coming up next here, in that I have seen a really great way to use telehealth to support people, to answer their questions, and to keep them going during this time. So I see that we are vital in terms of the rehabilitation care, as well as what Darren was mentioning in terms of the acquired weakness from being in the ICU and not moving as much, or possibly just staying at home. I mentioned 2 weeks ago that we're also offering classes, which has been really well received. So we'll hear more from Allison. We'll hear more from Allison on this telehealth in a few.
Thank you, Anne.
And you had made a comment in the chat about hearing from Sweden, because we have a new liaison from Sweden. Is Viva on?
Yes, go ahead, Viva.
Oh, I'll try.
Hi, Viva.
No, can you hear me?
Yes.
Oh, good. Okay, it's very hard to, hello. It's hard to answer, I think, on a national level. I think different parts of Sweden are coping in different ways, but what I find very positive is that daily PTs are being highlighted as essential in the care of these patients, which means that the general public will become aware that PTs, there should be a stress on the most needy. So thank you, Darren. Thank you very much for what you said. And 43 years of PT, I'm so happy about this. Although the situation that has brought it is so very tragic. My colleagues who work in wards at the hospital have a lot of work to do because, for example, the patients are confined to the rooms, which means that a visit from a PT, for example, in the hematological department, is just life-saving. So you can go on moving and being inactive. And there's also been on the national news about PTs who can work with patients so they do not, for example, have to go into respirators, saving them from respirator care, although they are in hospital. And the last week, there has been every day, I think, about the need for rehabilitation and how to cope with this. And I know from Stockholm that they are a bit worried because a lot of the general practitioners have been told to shut down and not receive patients because Stockholm is the area that is having most problems. And I'm in Lund, which is the very south of Sweden, right across the strait from Copenhagen. And we are just so blessed with it's not that we do not have cases. We have people in hospital here, but we're not close to Stockholm. But as a general, what I would like to say is that PTs here are doing a great job, as everywhere. And we'll try to answer the questions you sent. We're having a meeting, and we'll try to be back with a written answer to you, the questions you've made. Thank you.
Thank you. Thank you, Viva. And welcome. Viva is our new liaison from Sweden. She's new to this group. And I'm so happy that you're doing this for us. It's going to shed more light and give us, a more well-rounded background for what's going on internationally. Thank you. Any final comments before we have Allison come and present? Either, okay. There is one question. We're wondering where people living with cancer and other disabilities are going for rehab right now. And, I guess from what some of the things that people have said in the community places, I guess it's if there's places available and if the patients feel safe going, they're there, but it's very inconsistent and most places are closed down. Anne, any comment on that? Nope.
No, I do not have any comments on it. I've just noticed that must be, the people that I've worked with seem fearful of even going out.
Jackie, I can make a comment. Thank you, Anne, for pointing that fear-based. And I think that's the psycho-emotional piece that we need to really address as well as we begin to move from telehealth or telerehab to bring our patients back to our centers and community-based programs. We're doing a clinical trial right now on health coaching for cancer survivors. It is actually easier to get these patients into our health coaching study with the University of Delaware and Stockton University than it is to get reimbursement for telehealth, at least here in Delaware, where I reside. So it is very interesting. And we at the Helen Graham Center, our cancer center in central Delaware, we are just beginning to open this week. So it's taking a lot of convincing for administration in a large health system to realize that these individuals are losing range of motion because we can't get them in for the radiation. So it's become tremendously challenging because we have to address the fear of walking into the doors of our centers. And that's something that we have to assure safety and, clearly a way to increase that self-efficacy to walk in and lessen the concern of contagion for sure. But it is, as Jackie points out, it really is disparate. At least I know in my region that there's different levels of re-entry for patients with a sustainable telerehab to the degree to which patients wish that. Thank you.
Yeah. Thank you, Mary Lou. And that's a great segue now. So I think right now what I'd like to do is welcome Allison Kelly. She's going to be talking specifically about telehealth. It's part of her PhD studies at Queen Margaret University. And I'm so glad that she agreed to come and join us. I kind of roped her in last week when she was talking about her PhD studies. And it seemed like a lot of the comments that I've had, there's no evidence yet, or there's limited evidence for telehealth. So without further ado, Allison, would you like to begin speaking about your work there at Queen Margaret University and your PhD studies, and then give us some information about what you know about telehealth, okay? And I'm gonna turn my audio off. Thank you, Allison.
Thanks, Jackie. I think Anne has my slides there. So first of all, just while Anne gets the slides up for everybody. So yeah, welcome to IPT-HOPE's second webinar. So it's brilliantly organised to discuss and highlight these strategies and have these really good conversations, you know, about the management of people with COVID-19 plus HIV and our cancer patients, which to me are quite invaluable and you know, a really great opportunity to share our learning and to network around the world. But yeah, so my name is Alison Kelly, and prior to going into academia and research full-time, I was a specialist physiotherapist in oncology and hematology. And as a result, my research interests are predominantly within this area. Sorry, is there, can someone mute their microphone? Okay. So prior to going into academia and research, I specialised in oncology and haematology, and now my research interests are predominantly on rehabilitation and technology enabled healthcare systems. So I had done a master's in oncology clinical research in relation to rehabilitation with breast cancer patients, and now I'm doing a part-time PhD as well as lecturing, trying to look more into rehabilitation through digital technologies. Yeah, so I guess we can all agree then, you know, as a result of COVID-19, there's been a rising trend of remote healthcare systems, commonly referred to as telehealth, and that the rise in technology-enabled systems has definitely allowed for you know, for a better administration of treatment for our population group remotely and at their own homes in order to minimize the risk of transmission and infection. You know, as a result, healthcare providers, you know, we've begun to realize and to recognize the importance of treating patients remotely, and subsequently we've seen a rapid scale up of telehealth during this pandemic. However, like with this rapid implementation, there comes requirements for us as healthcare professionals to rapidly adapt to these new ways of working. So, you know, whether it be through academia, like bringing all our things online, online education, but also us as clinicians in how we work and how we treat patients and our assessments, you know, which is why special interest groups such as IPT-HOPE and all of us here today, like networking and giving these shared learning experiences is of the utmost importance. So yeah, so as the saying goes, I think we're in this together. So let's see what we can learn together about the telehealth response to COVID-19. So Anne, if you can, yeah, so I just put together a few objectives because telehealth is so broad. I focus on a few areas, and that is primarily that the basic landscape of what telehealth is within healthcare, the various options of telehealth, and I'm going to give you all an example of one system or a platform that we use successfully here in Scotland in the NHS Highlands, which was actually rolled out well before COVID-19, but now has seen an uptake in the use of its platform. And we'll also then get to discuss some challenges and opportunities to the advancement of telehealth within our oncology and haematology patient population group. So next slide, please, Anne. Thanks. Yes, so COVID-19, the digital spark. So I think, you know, as awful as this global pandemic is, you know, if there is one good thing that comes from COVID, then it will be like this digital spark that healthcare has needed for many years. And prior to COVID-19, you know, digital medicine was already changing the way people interacted with healthcare. And now this pandemic has increased its need, it's increased its drive, and it's also increased its acceptance by the public. So here in the UK, telemedicine services already included telephone triage systems and the ability to have video appointments. Here in Scotland, we had already implemented a remote monitoring platform. It's registered and it's trademarked called Near Me, and that was implemented in order to provide equal access to some of our patients who who lived remotely throughout the Highlands in Scotland. So you can imagine now, as a result of COVID, its use has tripled. You know, we've also seen how smartphone apps have helped patients to self-manage and order repeat prescriptions, and we now see more than ever how remote monitoring is changing the way care is delivered. So where I am particularly passionate about is the role of technology can play in providing rehabilitation to all of our cancer populations throughout their cancer pathway and beyond. Like here in the UK, almost 90% of the population regularly use the internet. Yet prior to COVID, less than a quarter had actually registered for online services with a GP. But as a result of this pandemic, you know, that has all changed now, and it's now is an opportunity in which we can collaborate with tech companies, and we can work with patients to, you know, co-create applications of digital technologies which meet their healthcare needs through tech-enabled healthcare system. So I feel really passionate like that we need physiotherapists to be among those who lead digital innovation in healthcare, both in the acute response to COVID, but also the rehabilitation following COVID, and for the recovery and regeneration, like of all those other services that physiotherapists provide, you know, especially when you think of all our oncology patients whose treatments have been delayed and postponed, in which there will be future implications for the care of patients with a cancer diagnosis. You know, and as a result, you know, we really need to be innovative, we need to be dynamic and open to change, and above all, like prepared to use telehealth. And as a result of COVID, you know, as Darren has said, you know, I've really seen that in spades, like there's so much of an uptake of physiotherapists within this area. We know that telehealth services, you know, can effectively improve access to healthcare for people living in rural and remote areas, and this has been seen in research carried out in Australia. However, there's telehealth services, they're not mainstream or routinely available, and the barriers to integration of telehealth, you know, has well been described, but not the factors that actually might influence the success and the sustainability of this service. So in order for telehealth to succeed, I think, you know, we really need to know these influential factors that drive the uptake and the promote equal healthcare for everybody. So next slide, please, Anne. So it was just a quick slide basically on what is telehealth, because there are so many terms branded about. It's just good to quickly ask yourselves, you know, what telehealth is and what it involves, because huge advancements in the healthcare industry has come with new breakthroughs in technology like telehealth and telemedicine, and both these technologies are used interchangeably, so describing the use of remote devices or the diagnosis and treatment of patients remotely. You know, there are numerous overlapping concepts, multiple definitions and terminologies exist, for example, like digital health, telemedicine, telecare, telerehab, telehealth, you know, and terms are sometimes poorly defined, and subfields then can overlap considerably. Telehealth is based on preventative measures, remote monitoring by using, for example, personal wearables, like we nearly all have one these days, like smart applications, you know, whereas telemedicine, for example, can encompasses like consultations and can have different and real-time communication paths, such as like medical records or a clinical portal to a patient mobile device. I think what's really important for us to note is that telehealth comes under a broad term by what we know as e-health. And it's important here to note that some evidence and research has recommended the expansion of telehealth broadly to include digital tools beyond what are interactive in audio and video. So for example, healthcare providers on the front lines of COVID-19 have identified, you know, that some older adults prefer telephone use to digital telecommunication interactions because of lack of technology understanding and training. And I think we as physios need to be mindful of this when we're treating our patients, you know, in identifying what is their preferential choice. So next slide, please, Anne. Yeah, again, just a quick slide on like our concepts and terminology. So we can see that eHealth encompasses telehealth, telemedicine, and another subgroup known as telecare. And eHealth is typically more like policy-driven, system-centered and controlled, whereas in areas such as telecare, you know, they provide all of these wearables like, you know, your Garmin's, your Fitbits, in comparison, and they're typically more consumer-driven and user-centered, and they're less like controlled. So incorporating them into healthcare is a lot more difficult because there isn't one standardized approach. So as I said before, you know, telemedicine, they're frequently confused, but in general, they're under the broad concept of eHealth. However, like despite their similarity, each one refers to a different way of using information and communication technologies to deliver healthcare services. And the slide was an attempt of a diagram to show like some conceptual framework of the relationship between each of those terminologies. So in essence, yeah. So bearing that diagram in mind, we can see here your differences. So we know that telehealth is newer and a broader term, and in comparison then your telemedicine is the subset of telehealth. It involves the use of like modern information technology, two-way interactive audio video communications, telemetry to deliver health services to remote patients, and you know, monitoring and communication-based services. So simply put, you know, telehealth offers an alternative way to delivering healthcare and practicing medicine. And the only difference to traditional care is that our patients and the clinician obviously are not in the same location. You know, it gives patients easier access to care while enabling clinicians to share, you know, expertise beyond their physical location. However, I think we do have to acknowledge that it's not for everyone, but patients are becoming a lot more amenable to this idea. And, you know, COVID-19 has sparked this. So next slide, please, Anne. So yeah, I wanted to talk about opportunities. So telehealth now more than ever is so important because, you know, our healthcare systems from across the world are facing several challenges in our path to provide like sustainable and equitable healthcare to all. And I really think, you know, the conversation that we had about health inequalities, like telehealth can help to bridge this. And I think, you know, we know that there is an increasing rate of cancer diagnosis, increasing cancer survivorship, and there's also increasing size of elderly population, growing incidence of chronic diseases, and increased demands from patients for more quality in the provision of healthcare services, you know, even to the supply of our workforce, and, you know, now in relation to PPE as well. And it makes it more difficult to accommodate this growing demand. So therefore, you know, the drive for telehealth to be incorporated into our healthcare systems, especially within oncology and hematology, is crucial. And we really need to work hard to implement it. You know, as a result of COVID-19, you know, the opportunities, for example, rapid implementation, like technology is being implemented rapidly within our healthcare system here in the UK. For example, from my perspective here in Scotland, everyone now has access to Microsoft Teams and potential use of what we call a platform or a product we use here in Scotland called Attend Anywhere. So this is used here, which I'll explain later. I don't think it's available all over the UK. So we are actually quite lucky here in Scotland with the use of that platform. Secondly, as a result, you know, we have seen information governance being more open to exploring like all the options and the advice from Scottish Government, encouraging the use of mobile messaging, video conferencing, home working, and using your own device, like where there's no practical alternative. You know, but they do advise that you should always check with your employer, you know, that there's no alternative available, you know, before using like off-the-shelf products like WhatsApp, and, you know, considering the implications like of implementing remote products before you begin. Thirdly, I think an opportunity that's worth mentioning is like the public and the clinicians, I feel, are more open to technology now due to its necessity. And, you know, when the world about us is constant, like the smallest of change sometimes can seem massive, but like now at the moment, the world about us is changing so rapidly, like what we see every day now as a result of COVID. And I think it's easier to accept that small change as just another new thing. So we really do have an opportunity to implement here. You know, people are getting involved in technology at a rapid rate, and especially some groups who are notoriously difficult to reach with technology. So for example, our elderly population and some patients with long-term conditions. Fourthly, I think we have seen great collaboration with industries where they are offering access to platforms at pace and often at reduced rates or even free. And it's this collaboration that we really need to seize and grab it and move forward, especially within oncology and hematology care. You know, there are a number of paid for products or additional functionality being offered at reduced rates, or in some cases even free, as a result of COVID. And now is the time to make the most of these offers and optimize the use of any available hardware and software, and really collaborate with our tech companies to drive like our healthcare system forward into a more telecare orientated. And finally, I wouldn't be in academia if I didn't mention research. So, you know, this is a huge blank and wide landscape of research within our field, and it's ready and waiting to improve evidence-based practice for our patients and our services. And you know, the lack of robust evidence, it offers us a great opportunity to evaluate the different services offered and be a part of this wave of new evidence supporting the use of digital healthcare. So this is an area that I'm extremely excited about, and in which my PhD involves the research into the development of such technologies. So I only started this in January, so I'm part-time, so I have 6 more years to go, so I'm quite at the early stages. But this is why educational and network sessions, you know, provided by Jackie, Anne and Darren here, you know, are crucial to network and to develop and to add to our evidence-based care and research. Okay, so next slide, please, Anne. So I'll just quickly skim through this, just from considerations, like, you know, it goes without saying that we as physiotherapists, we need to comply with all our regulatory requirements and deliver the same effective care, whether it be remotely or face-to-face. So ultimately, it's up to you as a physio to decide if tele-rehab is the most appropriate and best available way to deliver care to your patient. So I feel things we need to consider are that, you know, this is an emerging situation, and as Garrett has mentioned in his previous presentation there, that guidelines are changing all the time, and we really need to comply and to be up to date with all of these guidelines. And secondly, you know, we need to consider, is an in-person hands-on examination needed to complete the assessment and to determine, you know, our clinical analysis or treatment goals and our plans. And thirdly, you know, are there any like physical or cognitive or sensory deficits that make the delivery of physiotherapy using telehealth, you know, unsafe or ineffective? You know, we also need to consider, can someone be available to assist the patient if it's needed at their location? And also, how do you protect the safety of your patient's personal health information? So, you know, looking at confidentiality issues. And then lastly, you know, asking ourselves, are we really competent in the use of technology and its capabilities, and also, you know, its limitations? So most importantly, I think, you know, we really need to have a plan in place to deal with any potential adverse events, such as patient medical emergencies, you know, failure of the communication technology, or even environmental hazards. So, you know, being prepared, having these plans in place. And of course, you know, we must not forget about informed consent, similar to research, having that discussion with the patient and providing them with all the information they would need to make an informed decision about their care. So, you know, for example, including things like the difference between in-person and tele-rehabilitation, or services including options to receive, you know, the risks to their privacy of their health information, or any safeguards in place to reduce these risks. So again, that informed consent process. Just a few quick considerations to consider, you know, before your session. Maybe you might want to consider sending, you know, your patient information on how the consultation will work. offer them a choice of platform if you have that available. You could also, offer a pre-appointment practice run to ensure that the tech is working at both ends. And also important to inform the patient of where, self-management information is located, and to, share appropriate information in advance. And always, ensure that the local emergency escalation pathways in case they're needed. During the session, it's important in your assessments to minimize any distractions, be vigilant on the screening, given clear and succinct information, maintaining obviously your professional appearance, uniform and background, all of these things to consider during. And then when ending your session, reinforcing the key learning points, and double checking that your patient understands them, informing the patient that you're going to close the session, and then giving the patient obviously opportunity to ask further questions during the consultation and at the end of the consultation, and providing details then to get in touch. Okay, I think next slide there, please, Anne. Okay, good. So I wanted to offer you a perspective of what's rolled out here and used in Scotland. So here in Scotland, we use a platform tool that was developed called Near Me. So it provides an invaluable tool here in the fight against coronavirus, and it means that people can receive urgent healthcare and advice remotely from the safety of their own home without exposing them or our NHS clinicians to infection risk. So the NHS Near Me, it's a video consulting service for outpatient appointments, which take place in the patient's own home or at a local NHS premises. So it uses secure video consulting, which has been approved as private and confidential by NHS Scotland, and it's quite secure. As well, this project was funded pre-COVID days. It was funded by TEC, so our technology-enabled care, and they support research here, where outcomes for individuals in home or community settings can be improved through the application of technology, such as Near Me. And that was an integral part of the quality and the cost-effective care and support in which we're implementing to look after our patients. The NHS in Scotland and the care sector have been using this telephone and Near Me video consultations so that people can have urgent health appointments from their own home. And it's really helped to reduce exposure and the spread of COVID, while allowing care to be provided. And as we move into the recovery phase, this platform is set to be extended and to provide routine appointments across both our primary and our secondary care. And, it enhances that remote assessment and reassurance over the phone. Okay, so next slide, please, Anne. So again, this Attend Anywhere Near Me. So again, this, we're extremely fortunate to have it here in Scotland, and it's an available standalone audio video platform that we set up through an NHS email address. It's protected by higher tier security, and Attend Anywhere, it was branded here. So I think it was originally set up in Australia, and then it was branded as NHS Near Me by most NHS Scotland health boards. You need appointments can be booked in advance, just like any other outpatient appointments. You need certain requirements, so and your secure video consulting. Okay, next slide, please, Anne. Okay, so just with that example, this global pandemic, it's really thrust our physiotherapy profession and our society into this digital practice and telehealth. And because of social distancing and stay-at-home restrictions, we're really in a challenging and unique situation that magnifies these opportunities in digital practice. And as practitioners, we may lack some necessary telehealth competencies, but COVID-19, it presents digital practice opportunities, for us to improve access and safety in physiotherapy services for both the user and the provider. And telehealth provides this interactive audio telecommunication which will be beneficial and which can be implemented successfully. In Scotland, from a physio point of view, using the Near Me application for review appointments has really helped. The benefits of this are large, from the reduction like in travel time for patients and staff, and now obviously because COVID-19 is preventing, for your transmission and the risk of infection. We also see the value of this for patients whose conditions make it difficult to attend appointments with or without family support as well. Next slide, please, Anne. So the COVID-19 pandemic presents like unprecedented challenge to our patients, as Darren has amazingly presented in the last presentation. And here in the UK, I think that need to direct all our efforts appropriately towards providing emergency supportive care to those with disease. Some outpatient activities were cancelled by some trusts. And, I think like while this appears to be a pragmatic approach to reducing the risk of transmission, there's going to be an unmet cost to those patients in the future. And, as Darren had previously mentioned in his presentation, we see how oncology deaths are increasing, and worryingly, cancer referrals are decreasing. And, cancer doesn't stop, so neither should we, nor should the delivery of our services. And, how do we get this balance, and, what can we do? And I think telehealth, is this great opportunity. I think shifts in outpatient care delivery obviously will pose challenges, but and there are increasingly difficult decisions where clinical decisions regarding delay of treatment for patients who are currently undergoing chemotherapy or about to begin, or for example, our solid tumor patients, adjuvant therapy with curative intent, should likely obviously should proceed, despite the threat of COVID-19 infection during treatment. For patients with metastatic disease, treatment delays, could worsen performance status and loss of that window of opportunity to treat. So there are so many challenges with our patient population group, and considerations should include how such delays may lead to admission for symptom palliation, which then further stresses our inpatient resources. And though cancer surgery, it's not considered elective, surgical intervention, it also needs prioritization. And, there was currently here a ban on elective surgery in our system here in Scotland due to the limited availability of PPE, staffing and our bed capacity. But, these changes obviously were necessary. But for example, what challenges then is it going to present for our oncology population group? Okay, I think next slide there, please, Anne. Okay, so you'll be glad to know this is my last slide. So just to conclude on the potential challenges within telehealth. So, the limitations and the potential challenges that may exist include our inadequate technology, limited knowledge translation, and regulatory barriers, that can impede progress for service users and providers. With regard to implementation at pace, so there's little time for trial and error, and little time for pilots to, for rapid evaluation and improvement. So I think, small PDSA cycles of change are clearly needed. There's also little time for in-depth training. So peer support, like what we have today, is really essential, and clinical expert groups, can play like a vital role, in that support. When we talk about implementation at scale, we can see like the significant costs of new hardware and software, but the cost of inaction is going to be way more significant. So if cost is a barrier, then think about presenting a simple cost versus benefit presentation to your employer. So don't forget, about the more technical aspects of implementation, like our Wi-Fi, our bandwidth, the server capacity, and make use of our IT colleagues. Also, when we talk about patient access to technology, I think not all patients have access to the hardware and software or connectivity. Certainly here in the Highlands in Scotland, we have a few problems, but so we really need to make the most of digital platforms available. And my advice would always be to keep it simple enough to work and simple enough to access, with enough technology potential for possible good clinical interaction with our patients, and that can be further developed. And then finally, the lack of robust evidence. So there is clinical evidence on the efficiency and accuracy of telephone and video conferencing. However, it's driven by tech-savvy clinicians and those patients who are willing and wanting to take part. And almost none of that research, is done at scale that we're currently seeing. So we do need more research to prove its inclusivity and its accuracy for non-tech savvy users at the end of the interaction. So next slide, I think, was, yeah, like Darren, I don't have a conclusion, but I mean, I think what I would like to say is that this is a huge opportunity for dialogue among physios, telemedicine providers, and our patients, in which could result in, a much needed and timely collaborative practice based on current evidence and, our societal needs in healthcare. And I think with these stay-at-home restrictions, digital practice is supported as the way forward, with many countries recognizing the benefits and the value of using telehealth. And the body of evidence in relation to telehealth is limited, but excitingly, there are so many questions to answer through research. There's an opportunity for our role as physiotherapists to be advanced by embracing telehealth and embracing these networking opportunities and these educational sessions provided by Jackie and Darren, IPT-HOPE, and learning together new ways to reach our cancer and hematology and HIV patient population groups. So it's quite an exciting time. So thank you.
Thank you, Allison. This was amazing. Thank you for giving us examples from your own country as to how you're trying to get this organized. I think it's a great example. Just a quick question from me. How would you, because I think people are using telehealth right now in their clinics. How could they do a simple study or educational group? Like, would they start with a networking session where they share information about what's working and what's not working in telehealth?
Yeah, that's what we have done here in Scotland. Similar to this, we've had like webinar sessions and like sharing of experiences, networking. So we've had neuro rehabilitation teams using the NHS platform and sharing experiences then with pediatric outpatient teams and exchanging tips, exchanging tips on the best clinical assessments via telehealth, and when to know, I think is important as well, when to know and highlight red flags. Yeah, so definitely peer support is.
Okay, there's a lot of comments thanking you for this information and the insight. I'd like Anne to comment because she's been using telehealth pretty extensively and she's got online sites. So I just want her to comment about how she's using it with her patients. Anne?
Hi all. Yes, so we implemented telehealth as our patients kind of phased out of being face-to-face. And I don't see it as a substitute for face-to-face, but it's been working pretty well for the patients that have selected to come in. So when I identified that people didn't need to be coming in, I actually would be face-to-face with them and try the system that we had in place. So for instance, one patient was very concerned about it. So I went in the other room. At this point, we were already wearing masks and washing hands and using standard protocol. And they felt a lot more comfortable when I talked them through the telehealth paradigm. And then when we implemented, I would send them a invitation and we would do a number of things together. They would they would get online with each other. We would get online. I had a either by telephone or by a telehealth platform, and they would tell me what their main concerns were that day. I would focus in on their concerns for that day. And then I would go through and either update their home exercise program, go through the exercises with them, which I found improved their self-efficacy and ability to feel confident about what they were doing at home. And that's in a nutshell. I'm just going to acknowledge it. We're at the end of the hour. But I have found that I was been amazed with the people that were older with and without cancer, but because I see mainly older adults, that they were able to negotiate the site that we used and or telephone.
Yeah, and I've had some comments from other people. Obviously, you can't do hands-on care, but you can maybe teach people how to, and it was related to lymphedema. You could give them exercises or gentle massages, so it's better than nothing. But, you know, obviously it's not as good as having the PT with their expert skilled hands to do things. I think, Anne, you were also telling me you had a patient who had some cognitive dementias, and she was doing really good, like with a few prompts as to how to get on the system. And then you were able to help her learn to sequence it. So just your verbal prompts with her sequencing did well for her.
Yeah, so verbal and worked out pretty well. It really is better when you have the video because I could demonstrate. Mm-hmm. I would also have the patients count with me, and somebody is asking, how do you know if they're improving? Well, number of reps that they're able to do of an activity, that they haven't fallen since the last time you saw them, the number of steps that they're taking at home. So I can ask them specific questions. I also have get feedback from their families that are in their bubble with them or self-containing with them, that they're doing well. And then I also have gotten negative feedback of the few that I've told you that have ended up back in the hospital. One gentleman I was seeing face-to-face at his home, and he had a fever one day that I went in, shortness of breath, oxygen was down to less than 88% PO2. And I actually recommended that they take him to the hospital because I did not like his signs and symptoms. And so monitoring people through objective measures has been very beneficial as well. And I can send people information by text or email as well.
Okay, Darren has a useful website. So does Mary Lou Galatino in the chat room on an EDGE task force. Because some of the questions are, how do you monitor patients' progress, as well as what platform are you using?
Sorry, Jackie, was that for me?
I think that was for Anne. It said, okay. Anne, how, but yes, you can answer this too.
I was reading Nicola's question. Sorry, she had asked me about the Attend Anywhere. So yeah, I think it's more for those patient consultations, and yeah, with those it takes up to the groups of 5. I think you're right. So for those patient group, you know, exercise intervention education groups, and you might want to use more, they are using platforms such as Zoom. But you know, there's so much progress that can be made, and it keeps on developing at the moment. So who knows, Nicola?
Okay, let me see. And again, from Vasily from Turkey, she's asking, how do you monitor patient progress and movement? And, you know, if they have a joint limitation and it's required, I assist my patient in carrying out the movement. So essentially the patient access to technology is a challenge, but how do I manage to treat my patient assuming there is a joint limitation and it's required I assist my patient in carrying out the movement? Yeah,
I mean, there are always going to be challenges in you know, ultimately physiotherapy, it is a hands-on profession, isn't it? And I think, you know, this is what COVID-19 has presented us with, this challenge, and it's a great opportunity for us to be, you know, innovative, but it's also a great opportunity to promote self-management, and as Anne was saying, you know, that self-efficacy back to the patient. So for example, joint range of movement, well, you know, what other techniques can we do? You know, you know, depending on the joint, you know, can we do passive, active assisted, you know, going back to our basic principles of rehabilitation and, you know, that self-management of our patient population group, and just being innovative and thinking outside the box.
Yep. Anne did post that Doxy.me is free and it's easy to use, and she says Medicare, which is one of our major insurers nationally, is a little lax right now on which platform to use. But the Doxy.me, I think it's been approved. There's a lot of good conversation going on in the chat line where people are responding to each other about platforms and group exercises and how many people can be on at a time. Really briefly, I've been teaching online for about 10 years now. But I teach to post-professional students, so people who are coming back for DSCPTs or certificates in, you know, oncology or orthopedics or whatever, and research. And I find that I do less spoon feeding, because actually these are now professionals who have the hands-on care. And what I do is I line up all the things that they need to see or watch, or videos, or interviews they have to do, or things they try. And then I have them film themselves and present it at our meetings. So I actually find that I can have them like film themselves, like doing an exercise test, you know, on a cancer patient. And I can grade the test and, you know, see that, and they're showing me what their blood pressure measures and, you know, heart rates are, and sequencing, and that they don't forget things. And I think I can make the online sessions not harder, but more intense sometimes than in the classroom, because if I'm doing a lecture in the classroom, I'm really more spoon feeding them. Whereas if I'm doing an online presentation, I've recorded my didactic lectures, and then the in-person session is really where we're getting down to business about their questions, you know, how I can correct them on videos. And I think the online teaching is really much more, it can be much more intense. Obviously, it's not going to work for some programs like in orthopedics or neurology where you're guiding patients, but you can still model a behavior and then see at least that they're putting people in the right positions. You know, obviously it won't work again if you're looking at pressures. So any further comments from people?
I think there was a comment there. Many of our clinical sites have offered to take students for internships as long as they can use telehealth. Have you had experience with tele-supervision of students? And if so, can you provide some hints? So I don't have experience with tele-supervision of students, but actually it was a research project that I have proposed, you know, how actually as education providers and in academia are we preparing our future workforce of tomorrow within telehealth. So if we see, you know, that telehealth is advancing and it's the way forward, and we need to incorporate, you know, a technology based healthcare system and improve on that. Well, actually, what are the technology skills of our physiotherapy students who are going out into the workforce, you know, and how are we as educators helping them, you know, because they are our workforce of tomorrow. And I think it's a really important aspect that we need to research in and to help provide them with.
Thank you, Allison. That's wonderful. And that reminds me, because most of my students that are post-professional are between 40 and 60 years old. So sometimes just getting them used to using the software, now they are doing more telehealth because they're comfortable with it. So that I didn't think about that as a side benefit for them at this time. So any further final comments here? And Mary Galatino says, thank you, Jackie and Ann, for such a rich engagement with my colleagues across the globe. Happy Mother's Day to all. Thank you for being here, Mary Lou. Okay, so I want to thank everybody for such a rich presentation. You know, Darren's thoughtfulness and insightfulness about what he's lived through and what he's thinking up for the future. I want to thank Allison for being brave and coming and presenting in the early stages of her research. And I want to thank everybody for your thoughtful comments. This is so important for us to keep together because I think we're learning from each other. And there's the chat line is lighting up right now. Thanking you all, Darren and Allison and everyone who's commented. Ann and I are planning to have another session in 2 weeks. We might change the time because we want to make it more available for people in Asia and Australia. What we're hoping to do is have a report from the liaisons about how things have changed now that things are reopening and what's successful and what's not quite so successful. So I'll send out questions to them, and then we're going to allow you maybe 5 slides to present what's going on. And then if we have time, I'm thinking there were some requests for looking at evidence for practice during this time. And 2 weeks ago, we had talked about going back and doing chart reviews because you can get some valuable information from the charts that you've already used as to predicting how people are going to improve, what the outcomes are going to be based on all the restrictions in the world right now. So we might have a little bit of a research session. We're still brainstorming and working on this as we go ahead. So again, I want to thank everybody so much. I want to thank Ann for helping control this with the Zoom website. And I really want to thank Darren and Allison, our speakers. For the people that have attended, again, there's certificates that you can print up and put your name on, so you can have 2 hours of participation credit for your portfolios. And thank you all so much for being here. Please stay safe. Take good care of your patients and your families. And I'm so proud of you all that you're all doing such good work, and we need to pat ourselves on the back and make sure that we get out there and advocate, for what we do and for our patients and our students and, our fellow colleagues. So without further ado, I'm going to say good day to everyone. Bye.
Thank you.
Thank you. Bye-bye.
Thank you.